Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well with your families and your patients. Dear viewers, today our topic is Ilizarov method for treatment of multi-component foot deformities due to osteomyelitis. And the speaker is Dr. Anatoly from Kurgan, Russia. I would like to request Dr. Anatoly to join with us from Kurgan, Russia. Dr. Anatoly.
Hello, everybody.
Good afternoon. Thank you for joining with us. Dear viewers, we have three learned academic experts with us. One of them is Professor Novikov sir from Kurgan, Russia, highly academician. I would like to request Professor Novikov sir to join with us with Dr. Anatoly. Sir, good afternoon. Novikov sir.
Good afternoon, dear colleagues.
Good afternoon, sir. Dear viewers, we have a legendary Ilizarov surgeon from Bangladesh, that is Professor Mofakharul Bari sir. I would like to request Professor Mofakharul Bari sir to join with us.
Okay.
Good afternoon, sir. Yes, sir. Dear viewers, we have another enthusiastic Ilizarov surgeon from Patna, India. That is Dr. Shamsul Huda sir. Dr. Shamsul Huda sir, would you please join with us?
Hello and good afternoon, everybody.
Good afternoon. Dear viewers, we have another learned academic expert from Kurdistan, Iraq, that is Omar Barabi sir. I would like to request Dr. Omar Barabi sir to join with us.
Good
Sir,
afternoon, everyone. Thank you so much. Good afternoon.
Thank you very much, sir. Dear viewers, today our topic is correction of deformity by Ilizarov, and this is a very interesting topic. I would like to thank Rajtv for live telecasting our program as well as Rajtv. Now, I would like to request our honorable speaker, Dr. Anatoly, to share his presentation. Dr. Anatoly, sir, would you please share your presentation with us, sir?
Yeah. Dear colleagues, my presentation is looking normal or abnormal. It changes. Yeah. Okay.
Yes. Yes, sir. It's fine, sir. It's fantastic, sir. Please proceed on, sir.
Okay. So today we are talking about Ilizarov methods for treatment multi-component foot deformities complicated of osteomyelitis. So prevalence of foot pathology, it is a very common pathology, and total number of patients with musculoskeletal disorders and foot disorders account for 25–13%, and foot deformities occur in 12% of patients with congenital pathology, and 70.5% of foot deformities are caused by the consequence of trauma and neurological deficits. So, typical local view of that patient, it is ulceration, deformity, scars, and some soft tissue defects. So, typical in that slide, you can see typical types of club foot by Demeglio, but is in our practice more often we saw patients with equine cavovarus foot deformity, Talipes calcaneocavus foot deformities, and Talipes equine valgus deformities. So, typical X-ray view of our patients with foot infection, with osteomyelitis, and some disorders with articular surfaces of the joints of foot. So our aims is a standard suppression of infection and recovery function of limb. Typical our treatment protocol, which one includes preoperative period, where we do blood tests, culture test, bone biopsy, MRI, CT scan, or X-ray pictures. So, and since the second stage revision, where we do debridement Next stage, reconstruction, where we do orthopedic recovery of limb. And one important that revision stage and reconstruction stage can be applied in one surgery. So, and last one stage, there is fixation, where when the patient can do functional loading on his limb. Some nuances for debridement of patients with foot and ankle infection. First stage, we do ultrasound debridement of wound. Next, resection of the corns and scars. And after that, we do resection of necrotic or sclerotic bone parts and resection of all osteophytes. And after that, osteosynthesis with correction, functional deformity of foot for stitching wounds. So, types how we do sequester necrectomy and how we do resection of the all osteophytes or some bone parts, which one stay in a high point of pressure of the plantar surface. So, and approaches for closures of tissue defects, there is can be simple stitch and wound, correction of foot deformity, as I told before, correction of foot deformity for stitch and wound, dermatension, and skin grafting. So, creation or correction foot deformity. As you can see on left picture, when patient had ulceration, and for stitching that wound, was made osteotomy of calcaneum for correction of deformity, and after correction deformity, we can make simple stitching wound. Another one technique, there is creation foot deformity for stitching wound. Like in that case, female patient with spina bifida, sequela, and she had ulceration on the plantar surface in the hind foot. And for stitching that wound, we create equinus position of the foot and fixed that deformity in Ilizarov fixator, and with that condition we can apply stitching wound here. And after that, after healing soft tissue, after healing wound, we gradually made a correction of deformity, and later I will show with more details the case. So, stretching of the skin, wound for soft tissue stitching, wound or soft tissue defect. Here is, you can see stages of stitching, of creation enough skin flap for next coverage of the wound ulceration. And for creation of that skin flap, where in first step we implant the sub-skin implants, and after that by Ilizarov we're gradually making tension of the skin, like a stretching, and after that was created enough for closure wound, enough skin flap. So, and protection of the skin flap, simple skin grafting method for closure wounds on the plantar surface of the foot. So, And for eliminate foot deformities, we are using soft tissue surgeries, osteotomy of the foot bones, and stabilizing surgeries. Here, as you can see, options for replacing some wires of the tibia bones in foot bones and in midfoot and upfoot bone. Typical construct of Ilizarov device with for correction of the deformity and standard soft tissue techniques for correction of deformity, like in that slide, achelotomy, lensotomy. So, and levels of osteotomy of the foot bones for some types of correction of deformities, like in that case, types of the osteotomy of talus, calcaneum osteotomy, V-shape osteotomy of the midfoot for correction of deformity of the midfoot, or for correction some deformities of the cover foot. Some types of tarsal bone osteotomy, osteotomy of the metatarsal bones, and V-shape osteotomy of the hindfoot, L-shape osteotomy of the foot, of the hindfoot, and articulated like a hinge osteotomy of the foot for equinus correction of deformity. Some types of the stabilizing techniques, like plantar arthrodesis, triple arthrodesis, subtalar arthrodesis, and ankle joint arthrodesis. And for example, patient with young patient with club foot from the left side of the deformity, complicated of the osteomyelitis, fifth metatarsal bone. In the first stage, where was made sequester necrectomy, osteosynthesis, and reconstruction for deformity correction of the segment. So after treatments, we take good results. Patients don't have a recurrence of the foot deformity and don't have a recurrence of infection, and have a good function of limb. Another one case, patient 35 years old with spinal injury and with equina cavavarus foot, right foot deformity, with ulceration, with the osteomyelitis of the fifth metatarsal bone. In the first stage was done sequester necrectomy and osteosynthesis of by Ilizarov. And because patient had some troubles with articular surfaces on the midfoot, ankylosis of the talonavicular joints, because it in first stage was done just sequester necrectomy and osteosynthesis with a little bit deformity correction. On the second stage was done osteotomy of the mid, V-shape osteotomy of the foot, and gradual correction in Ilizarov fixator. After treatment, patient have a good result, good function of his limb, and not have a recurrence of infection. Another one case, patient with osteomyelitis of the calcaneum bone. Calcaneum covers foot, and in first here is video how patient walking before treatment. As you can see, on the right foot, patient walking just using only hind foot, and the mid foot and the forefoot is not using in a step. Yeah. And in first stage was done sequestronecrectomy with Ilizarov fixator. And but after that sequestronecrectomy, patient was taken total bone hind foot bone defect, and for healing that bone defect was making reconstruction, like I show it in previous my presentation in previous our meetings. Was done was made healing that bone defect by staging osteotomy of the tibial, and after treatment, patient have good results, not have a recurrence of infection, not have a good walking, and in that video you can see it. I repeat, patient had problems with right foot, and now we can see how patient used the foot, how patient can use his foot in walking, and some important that here using simple shoes, don't use some crutches or some sticks. So, and in that case, we come back to a case with ulceration on the hind foot. In first stage of that patient was done debridement, and as I told before, the foot, we put foot in equinus position, and was fixed that in that position of the foot in Ilizarov fixator, and in that surgery we can apply stitching wound, and the total time of fixation in that position was 25 days. After that, we started gradually deformity correction. And for reloading of that of the scar after wound stitching, we make for that patient we make reload of the plantar surface by changes of points of pressure on his foot. By we made it by transport foot backwards on the hind foot here. So, and after treatment, patient not have recurrence of infection, can walk with full pressure on his foot, and one important that scar after ulceration place is reloading. So another one case, I show it before, and here is in X-ray you can see deformity of calcaneum, and here is how we made osteotomy of calcaneum for calcaneum deformity correction and stitching wound. As you can see here, this is line of osteotomy. So, and after treatment, patient have good result, no ulceration, no infection, and good function. Our about that technique, you can read in our articles where with all details we are published. So, and in conclusion, differential use of the Ilizarov method allows to slow the issues of stable termination of bone infection process and reconstruction of the supportability, implants and function, improvement of treatment, outcomes of patients with multi-component foot deformity complicated by chronic osteomyelitis. So thank you for attention.
Thank you very much, sir, for your excellent presentation. Now, I would like to request our honorable academic expert to share their knowledge regarding the presentation. I would like to request Professor Mofakrul Bari sir to share his presentation, to share his knowledge regarding the presentation. Sir, please.
Thank you, my friends, all my friends. Anatoly, I must say, these are fantastic cases that you have shown. Unique, excellent, excellent. Because by this time, I'm working same cases with 2 diabetic hospitals. There are a lot of cases. Our population is too much high. And these are all the cases, purulent, necrotic cases, getting lots of cases in the foot. And really, without Ilizarov, nobody can treat. Nobody can treat. Exceptional in the foot cases, Ilizarov is still the best. Infected cases, he could not put any kind of plate, screws, and other things in the foot. But with Ilizarov, following the principles and philosophy of Ilizarov, we can treat a lot of things. Dermatension, you have shown. It's very fantastically you showed dermatension. And the word sequestronecrectomy is commonly used in Russian Kurgan Center. In Western world, they don't use that term. I use this term all the time. Sequestrum, necrosis, they all the time they tell is debridement, whatever make this. The terminology is very good. Achillotomy, plantarotomy, sequestronecrectomy, the terminologies that you are using, and how to treat with infection with the different components in the foot, equinus, cavus, varus, you can correct simultaneously. And very importantly, I would like to mention here, without Ilizarov, you cannot control infection. No antibiotics can help you. If you don't properly apply you have seen the cases that he has shown only with the biocompatible thin Ilizarov virus or KOS. And I must say how he treated the big ulcers in the calcaneum, fantastic, dermatotension. In the midfoot, in the forefoot, in the hindfoot, and all the components of the foot you have treated nicely, you have shown. And that's why my suggestion is for the world orthopedic surgeon, you must go to Kurgan Center. They have a 2 osteomyelitic, 1 osteomyelitic and foot center. And to learn these things, and you can help a lot of people by using this Ilizarov in case of this infected different varieties of component foot deformities by Ilizarov technique. So thank you very much again. I enjoyed your lecture fully because by this time I'm working in 2 hospitals, in diabetic hospitals, very big hospitals. Our 2 hospitals, very big. So that's why I'm very happy, learned a lot of things. Thank you very much again.
Thank you, sir. Thank you for sharing your great knowledge. Now, I would like to request Professor Novikov sir to say something regarding the presentation, sir, please.
I want to say thank you very much for Dr. Sudnitsyn, because today he showed us very difficult cases. In our center, we have two departments for treatment of some problems with food. One clear department, and there usually doctor don't think, but we haven't any problem with soft tissue. We have X-ray picture with any deformity, so many deformities, and then by Ilizarov technique, frame, effect, our knowledge give us very quickly possibilities to correct any deformity of the foot. But Dr. Sudnitsyn work in another department, special infection department, and all our opponent Ilizarov method is risky because of infection, and when coming some infections, must doctor having another choice, must remove device and then treat with antibiotics, with another methods. Here, Dr. Sudnitsyn start from osteosynthesis. Patient has infection. Patient has severe problem with soft tissue, with big defect of soft tissue, and then by Ilizarov frame, but through the Ilizarov effect, we get everything. We get soft tissue, flat. And I want to ask Dr. Sudnitsyn about deformity. When he need a special create deformity, which kind of technique not give you effect? Which kind of patients you cannot get result with this technique?
With this technique, I don't know which is patients don't have result. Every patient have result, but of course, when patients have some troubles with blood in supply, here is deformity, creation of deformity and healing of the soft tissue defect can be slowly, and because it we are should fixed in functional deformity of the foot in Ilizarov fixator. We are should fixed that foot so long time, and because it after that fixation we can take another troubles like some disorders with the joints, especially with ankle joints, because we know that if we fix it without some reloading of the ankle joint in Ilizarov fixator, we can take some ankylosis of joint, and because we are not trying to do we don't try to create foot deformity for stitching wound for patient with some blood in supply. I think only that, but there is very not often cases, not common, maybe 1 or 2 cases in a year, not more than.
And I have only one point. This is only my opinions. I think foot surgery, this is a special surgeon. This is patient not for all of, with only doctor with high experience big experience can touch these patients. This is my opinion. Because during my life, I have only few patients, and send all of these patients to the special department.
Thank you very much, sir. Now, I'd like to request Professor Omar sir to share his knowledge regarding the presentation. Sir, please.
So much. Do you hear me? Okay, thank you for a nice presentation. I want to ask him, what about subcutaneous implant, the implant under the skin? What could be the role of that subcutaneous implant? And at which time he like to use it?
That subcutaneous implant, subskin implant, where there is our there is our technique. We some last time were very often used, but the technique have some troubles. I mean, for creation of that of the skin flap on a on a plantar surface need very more time, and that technique can be applied only in cases when we cannot do some skin grafting. For example, if patient have a ulceration like in that case on medial mid-foot place or forefoot place, and but patient not have a contralateral leg, I mean amputee stump on the another leg. So, and only in that cases we can use it. It is like a safe boat for surgery on that technique. So, and how we do it? Between ulceration and point of implantation of that some skin implant, we are safe 5 centimeters between ulceration and subskin implant 5 centimeters. And after we should implant that implant in between skin cover and plantar aponeurosis, yeah. And after that, after 5th or 7 days after surgery, we started gradual retraction of that skin implant by some nails and by Ilizarov. And each one skin implant we do gradually, and we do each one with eye control of the blood and supply on the skin point near with that implant. I mean, if we after traction that subskin implant, if we saw normal blood and supply and skin pink skin color, there is okay. If we saw white skin color, we should little bit relax traction of that implant, and in each one that implant we should do that traction with that control. And after creation enough skin flap totally, after that we can apply it some skin grafting of that ulceration.
Okay, thank you so much.
Yeah, thank you very much, sir, for your nice question. Now I would like to request Dr. Shamsulhuda sir to ask any question or share his knowledge regarding the presentation, sir.
Thank you, Dr. Tanvir. Thank you. Congratulations, Dr. Antoli, for such a wonderful cases, soft tissue heterogenesis with the use of subdermal buttons and wires. I have just one question for you. I've seen at times you have been using wires as hooks. and subdermal buttons. And many other surgeons have also been using extradermal plates for stretching. Which one you feel better, either hooks or buttons or plates for soft tissue regeneration?
Here is the technique we can apply it, how to say, every surgeon can some style of the surgery, you know what I mean. So and yeah, it's like a choice of doctor. Yeah, and what about me? I like some for creation of the for the protection of the stitches. I mean nail stitches. For protection of that, I like to input that G wires for protection only.
One more question. You have created Equinus deformity for the soft tissue lesion. After the soft tissue healing is there and you correct the Equinus deformity, is there any wound dehiscence seen after that? Recurrence? No?
Yeah. No, if you do it gradually, I mean gradually correction, it can be safety for soft tissue. I mean, in on the scar of the after stitching wound. If you do it gradually with a control again, yeah. So and it will be okay. Yeah.
Okay. Thank you. Thanks a lot. Wonderful cases.
Thank you, sir. Thank you very much, sir. I have one question. Sir. You are showing that there is a dermatotension. How much gap can you cover by this dermatotension? Is there any study there?
Oh, it's a difficult question because for example, now I have a patient with soft tissue defect on the plantar surface, 20 centimeters on a 10 centimeters, so big wound. And for that, we create some deformities, some deformities of the foot, and after that, gradually corrected. Yeah, very, very difficult question because every day we have that patients with different size of the soft tissues. And every patient is a unique, I think. Yeah.
Okay, thank you, sir. Thank you very much. Sir, I have one more question. Do you face any complication during this dermatotension or any challenges?
No, if you do it everything correctly and gradually and with eye control, no, I don't saw any complications. But I think if we do it without without control, without eye control, not gradually, I think we can take some blood in supply disorders of the skin flap, and from that necrotic of the skin, local necrosis of the skin between subskin implant, I mean. So, and something else like that. But in my practice, I don't saw before some troubles, some mistakes with the technique.
Questions, have you any complications, yeah? Because Dr. Sudnitsin start from severe complications and go away through the Ilizarov effect. Fantastic situation.
Yes, sir. That was fantastic, sir. Then you start dermatotension from day 7 to day 8. You just mentioned in your earlier speech.
No.
Please,
You can start.
Yes,
Third or
sir.
fourth day, you can start rotation.
You start your yes, sir.
Can you hear me?
Yes, sir. We can hear you, sir. Please, sir. Sir, we can hear you,
3,
sir.
4, or 5 days.
Start. Where start?
3 or 4 double rotation. You can start as soon as you completed your.
Yeah,
You don't need to wait for 7 to 8 days.
Нужно ждать.
Okay?
Yeah, I think much more better if we wait 5 or 7 days. It's much more better for soft tissue after surgery. We know that. Yeah, we know that soft tissue first 5 days have a post-traumatic, post-operative some infection, some, and because it's much more better if we will wait some 5 or 7 days.
I think this is depend of patient.
My one question arises, Anatoly. Do you take any kind of consultation from the plastic surgeon?
No, I have some private experience in plastic surgery, and because it's all plastic skin grafting, I do it myself only.
Okay, only skin grafting. Okay,
only skin grafting. Yeah.
Okay, sir. My last question, sir. The daily tension, how much tension you give in a daily manner, sir?
Daily, you can do it. In my experience, I do it maximum 5 millimeter per day. Okay. It's. I think it's normal. But if you do it more, you can see some blood and supply troubles, local blood and supply troubles. I mean, with the skin.
0.5, yeah. 0.5, 2 times a day, frequency 2 times a day or 3 times a day. If you go for 1 centimeter, it will not help you for in the foot surgery. 1 centimeter per day, not recommended. 4 times a day. 0.5 mm is better.
Yeah.
Sir, do you give any interval after 5 days or 6 days? Do you give any interval during this dermatotension after 5 or 7 days, or you will continue the gradual tension? No interval.
Yes, usually in a weekend we are relaxed for traction. I mean, so and because we should do eye control, as I told you.
Our patients need Juma namaz too, yeah.
And patients need to relax in the weekend. Too, yeah.
Thank you, sir. Thank you. That was a very interesting topic. So I asked too many questions. I want to learn from you. Thank you very much, sir, for presenting a fantastic topic. I would like to thank all of our team members, or all of our academic experts, and our honorable speaker. And I would like to thank Rajtv and definitely Rajtv and definitely Rajtv Pharmaceuticals Bangladesh Limited for sponsoring our program. I'm Dr. Tanvir Ashraf saying bye-bye today. Hope we will connect you with the coming Friday with another magical Ilizarov topic. Till then, I would like to say bye-bye to all of you. Bye-bye.
Okay, bye-bye.
You are watching Rajtv, Jagorone, Bangladesh. Please subscribe our channel.